Welcome to today's session titled Conversations with Grantmakers in Aging, Healthcare and Family Caregiving, What's the Connection? Before we get started, I'd like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or computer audio. If for any reason you'd like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time. We're going to collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar.
Thank you, Nikki, and thank all of you for joining us today. Before we get started, we want to thank the John A. Hartford Foundation of New York, which is the sponsor of this on a continuing basis, going on for 8 years now. So we thank them for allowing us to produce these webinars that are provided to you free of charge. In today's presentation, we will be exploring the connection between family caregivers and the healthcare system. Supporting family caregivers is an important driver in achieving stronger patient health outcomes and is a key recommendation of the National Academies study, the Family Caregiving for an Aging America, and the California Task Force on Family Caregiving. In Central California, the presence of a supported and engaged family caregiver is demonstrating results for both patients and caregivers. Ventura County Community Foundation and Dignity Health have started the Caregiver Navigation project, giving them the opportunity to engage family members as partners in the healthcare system. Today, we're extremely pleased to have two experts to speak with us about this program. Kathleen Wiggins is Vice President of Community Investments and Partnerships at the Ventura County Community Foundation, and Dr. Kathleen Sullivan is Vice President for Post-Acute Care Services at Dignity Health. We welcome you both. As we mentioned earlier, you can enter your questions for our panelists at any time in the question box you see on the right hand of your screen. Please do that, and I will be collecting those and asking our speakers those questions after the presentation. So, Kathleen, let's start with you, and let's hear more about this exciting project.
Great. Well, thank you, John. It's a real pleasure to join you all today to talk about the intersection of healthcare and family caregiving. And when we talk about family caregiving, it's quite likely that the face of someone you know comes to mind. Yeah, the caregiving experience is very personal, and yet it's so common that it's usually referred to as simply just, well, it's what we do. But today, there's a deepening acknowledgement led by AARP and other national voices of the critical importance of supporting family caregivers who, for all practical purposes, are the safety net for many older adults. Statistics tell us that healthcare utilization increases with age. And when acknowledged and engaged positively, this caregiving quote-unquote workforce has so much to offer healthcare systems who are looking to enhance patient outcomes and create value. Today, I'm going to talk about Ventura County's path to evolving its healthcare practices to incorporate the role of family caregivers using a model that was piloted at Marian Regional Medical Center in Santa Maria. During the second part of the webinar, my co-presenter Kathleen Sullivan will be sharing about the details of how this program works within the hospital. Next slide, please. So let me just tell you a little bit about my foundation. As a community foundation, the Ventura County Community Foundation serves the Ventura County region. This is an area with a population of over 850,000 just north of Los Angeles. We were founded in 1987, and we currently have over 600 donor funds representing a wide variety of interests. Many of our donors are living, and as strong fiduciaries, we work closely with them to align their interests with community needs and trends that they care about. We currently have net assets of $125 million, and our recent areas of focus have been on disaster response, both immediate and longer term, due to the massive and repeated wildfires in our area and a mass shooting in our county. we've been involved in convening the community to prepare for the 2020 census, and we're also focused specifically on caregiving for both the young and old. So you're probably wondering, how did a community foundation come to focus on family caregiving and healthcare? Well, that's a story in itself, but I want to first start by looking at the data, national data, state data, and local data in order to provide some context. Next slide, please. So back in 2016, a mere 3.5 years ago, the National Academies released its national study, and it was a groundbreaking study, the first ever of its kind, called Families Caring for an Aging America. An expert committee was convened to look at what is known about the nation's family caregivers of older adults and to recommend policies to address their needs and help minimize the barriers that they encounter when acting on behalf of an older adult. This study estimated that there are 17.7 million family caregivers caring for an adult over age 65 who has a significant impairment. The report acknowledged what many know from experience. Family caregivers must interact with a wide range of providers and navigate within a variety of systems, including and perhaps especially with the healthcare system. It may be physicians, nurses, pharmacists, therapists, and others that they interact with, but in that role, they serve as key sources of information about health histories, medications, previous treatments, and surgeries. They represent older adults in dealing with home health care agencies, hospitals, assisted living facilities, and nursing homes. Yet, in all these contexts, family caregivers are often marginalized, excluded from older adults' treatment decisions and care planning, while also assuming that they are able and have the knowledge and are willing to perform essential care tasks. It's clear that the family caregivers are performing a critical role in the health of older adults. So with this acknowledgement, the committee issued an urgent call for action to transform the policies and practices affecting the role of families in the support and care of older adults. Further stating, and I want to emphasize this, that today's healthcare emphasis on person-centered care needs to evolve to a focus on person-centered and family care. That's quite a shift in those few words. Next slide, please. In our state, the California Task Force on Family Caregiving was established by a resolution of the legislature to address the challenges encountered by California's 4.5 million family caregivers who care for individuals ages 18 or over. The work of the task force, which was funded by the Archstone Foundation and AARP California, issued its recommendations in 2018. The final report acknowledged that family caregivers are foundational to California's long-term services and supports infrastructure, surpassing Medi-Cal, which is California's Medicaid program, in terms of the economic value of their unpaid caregiving contributions. The report stated that caregivers are key members of the healthcare team, but they are often under-recognized. Once a care recipient is discharged from a hospital, caregivers are often left to complete complex care tasks with little support, training, or even choice. And of key importance for the conversation today is recommendation number 5. The task force recommends legislation integrate family caregivers into hospital processes, support them in navigating care transition and with providing complex care tasks, and increase caregiver choice in whether to complete complex care tasks. So these are national and state perspectives to provide some context. Let's break down the local data from Ventura County to learn more about what it tells us about the community, healthcare, and caregiving. Next slide, please. I probably don't need to tell anybody in this audience that the population is aging. Okay, of course, this is no surprise. It's as true in Ventura County as elsewhere across the nation. And led by the baby boom generation, the percentage of older people is growing as a portion of our total population. Given the reality of our demographics and the millennial generation, this trend is just going to continue in the future. In Ventura County in 2020, those over age 65 represent approximately 16-17% of the population. And this is expected to grow to nearly 23% by 2030 and over 25% by 2050. Next slide, please. The healthcare system itself is facing new realities. Healthcare is moving away from the acute care setting, and patients are being discharged sooner and sicker. While this practice results in lower financial expenditures, the unacknowledged cost of caregiving is increasingly being borne by unpaid family caregivers outside of the healthcare system who are being asked to absorb this demand for care. Hospitals are now responsible for patient outcomes for 30 days following discharge, and older patients with chronic conditions such as heart disease, COPD, diabetes, dementia, and others are especially at risk for readmission. In Ventura County, the provisions of the Affordable Care Act have resulted in penalties for Medicare readmissions for Ventura County hospitals year after year. As a result, hospital leadership is very open to finding ways to address the situation, and there's a willingness to consider new ways of doing business that demonstrate results. Now, let's take a look at what's happening after these high-risk patients leave the hospital. Next slide, please. Well, for the most part, they're being released to family members who are caring for them at home. AARP has done a tremendous amount of research in this area, and their studies indicate that over 80% of long-term care is being provided by family caregivers. As has been noted, these family members are being asked to step up and do medical tasks for which they are unprepared. Due to social realities such as smaller family size, the number of available family caregivers is declining, just as the demand for care is increasing. Over time, this demographic reality is expected to result in greater burden for those who are caring, as well as representing a challenge for the community at large. Ventura County statistics from 2009 show that 1 in 4 people is caregiving for an adult. Most are working, and nearly all are in their prime working years. And what are the caregivers themselves experiencing? Next slide, please. Well, caregivers themselves are not the picture of health. They delay their own medical care and getting prescriptions for themselves. They're at higher risk for high blood pressure and asthma. They're more likely to have serious psychological stress. And in a very troubling statistic, they're nearly twice as likely as the general population to seriously consider suicide. This is not a good picture for our long-term safety net. Need I say more? So really the question is, how can we change these outcomes? Can a community come together to embrace caregiving as a critical health issue and challenge for the present and the future? Can an older patient and their family caregiver experience better outcomes? And the answer to these questions is yes, and there is great reason to hope. So here is how Ventura County is coming together to address these issues. Next slide, please. Ventura County has a collaborative called the Ventura County Community Health Improvement Collaborative, which is a multi-sector collaborative of healthcare providers and community-based organizations. In 2019, this group came together to jointly conduct their mandatory community health needs assessment. Facilitated by the Public Health Department, the objective of the collaborative is to break down silos in healthcare and identify intersecting issues that impact the county population and the county population that these groups, all the members of the collaborative, serve. The Community Health Needs Assessment identifies and prioritizes significant health needs in the Ventura County areas and provides an in-depth understanding of the barriers to experiencing health. The purpose of the assessment is to guide efforts to address the identified needs and develop plans that offer partners the opportunity to leverage resources and connect residents with the means to improve health outcomes and quality of life. This intensive process involves collecting and analyzing community health data, conducting outreach, gathering surveys, and holding focus groups to glean as much data and insight as possible. And then there's the process of prioritizing the top community needs as a group. For Ventura County, questions about family caregiver status were included in the Community Health Needs Assessment survey for the first time, and the results were telling. Nearly 32% of respondents indicated that they were family caregivers, and most of these were caring for older adults. The collaborative group, identified age-related issues as a high-need area and prioritized improving the health and well-being of older adults as one of their top 3 health issues in Ventura County. So putting all this information together, the collaborative reviewed the pilot project that you'll hear about shortly. And with the engagement of the Hospital Association of Southern California, the decision was made to implement a multi-hospital intervention that would include social supports from community-based organizations that would help reduce readmissions for the Medicare population and support family caregivers. Next slide, please. After making the decision to prioritize the health and well-being of older adults, and pertinent to the conversation today, the collaborative specific strategy will be to reduce hospitalizations and readmissions among older adults by providing them and their caregivers with tools and resources to improve quality of care and care transitions between hospital and community settings. It's anticipated that these results will improve the quality of care by increasing coordination among health systems and community-based organizations, decrease the burden of care for families of patients, reduce the cost of care, and enhance client satisfaction. Next slide, please. The Family Caregiver Navigation project that was piloted at Marian Regional Medical Center / Dignity Health in Santa Maria will be used as a model to achieve these results. In 2019, the Ventura County Community Foundation funded the development of a toolkit to articulate the model so that it could be easily understood and incorporated into hospital settings. With the leadership of the Hospital Association of Southern California, this project was presented to all hospital CEOs in Ventura County. Consequently, when the Community Health Needs Collaborative identified the population of older adults as a focus priority, the hospitals immediately recognized that the caregiver support program could create the kind of outcomes that aligned with the Community Health Needs strategy, and it was eagerly embraced. Next slide, please. You're going to hear about how the Caregiver Navigation project works shortly, but from a funder perspective, I'd like to note some project particulars. First, this is a 3-year project, and at present there are 3 participating hospitals. This aligns with the 3-year Community Health Needs Intervention Strategy, as well as the Foundation's intention of 3 years of funding. Obviously, funding depends on, compliance with grant agreements and whatnot, but partnerships are a hallmark of this work, and VCCF has partnered with the Hospital Association, who led the outreach efforts, as well as with Marian Regional Medical Center in Santa Maria, where the project was piloted. Kathleen Sullivan is serving as a technical advisor to this project. The hospitals, the Hospital Association, and the Ventura County Community Foundation were involved in the Community Health Needs Assessment Collaborative. For the project, each hospital is building a network with social service providers in their areas so that caregivers can be easily connected to the services they need most. There is an evaluation component in tracking the outcomes for the care recipient, the caregiver, and the hospital system that will be built. Thanks to initial support from AARP, we've mapped out an entire evaluation plan with a variety of components that we'd like to learn about. Additional support will be needed for a robust evaluation effort. Based on the results of the initial pilot, we believe this model is scalable, but it needs to be tested in different contexts, and we're pleased that the 3 different hospitals serving different communities are part of the project. So now I'm going to turn it over to Kathleen Sullivan, who's going to share about what the program looks like within the hospital system. Kathy?
Thank you, Feline, and good morning to everyone. As Feline said, my part of today's conversation is to share our story, the story of implementing a caregiver program within one of the divisions of Dignity Health, the Central Coast Division in California here, and particularly in northern Santa Barbara County. Next. It was the Santa Barbara County Foundation, at the time under Feline's leadership, conceived of and funded the Community Caregiving Initiative, and Dignity Health was one of those fortunate awardees. Next. We spent a lot of time as a health system here I did in particular, thinking about why invest in a family caregiver support program. Certainly professionally, intuitively, personally, I knew that it was the right thing to do. From a hospital philosophy perspective, we believe strongly in person-centered care, in family-centered care. And at the time we were beginning this, I had just finished a long time caregiving personal episode with my late husband, who you can see up in the upper right-hand corner. I keep him embedded in this work that way. And in reading, as Feline brought forward, much of the original work on this that inspired us to jump into this space was the work the AARP had done. The Home Alone Family Caregivers Providing Complex Chronic Care, done in 2012, was probably the biggest, and as many of you may know, that was recently updated in the Home Alone Revisited last year. Next. So for us, as providers, professional providers of care in a health system, we recognize that our families, when they're living in the community, when they see us in an acute care episode and are ready to go home and many things have changed, that their families have to manage many things. We see over time that family caregivers are really no different than what we call care coordinators at various parts of our delivery system. The difference is that they don't know who their network is, and we need to help with that because it's a tough job. We also recognize that most caregivers have a lot of intrinsic motivation and want to keep their loved ones at home. They want to do the right thing. It's considered a privilege. The burden makes that difficult, so we just need to help. Next slide. And there's benefits specifically to us as a health system if we do a better job at enabling our caregivers to support the care recipients in these dyads. Then we have a much more prepared throughput system so that when these patients and their caregivers do enter our system at various touch points, they're more prepared, they're better advocates, and their stays are shorter, and they go home quicker. The work around this space does add to our portfolio of value-based services. When I say value-based services, I mean those things that are wraparound care and support. We want this program of supporting family caregivers to be no different than getting a dietary consult automatically if you're in the hospital. It's an automatic thing to support the caregiver. And again, back to our vision of embedding, we want it to be that simple. We were also, we were thinking also that the CARE Act in California was coming to be effective. It became effective in January of 2016. The CARE Act, for those of you who don't know, it was actually the culmination of the policy work that AARP did in putting voice to the needs of caregivers, that they are providing lots of complex medical care, and hospitals then need to pay very close attention to that, to include the caregiver in planning and in notification of certain milestones if they're an acute care patient, and to identify and put their name in the medical record. And some of those things were new to many hospitals, not so new for us, fortunately, but we were ready. And we thought that we could lower the rate of acute care hospitalizations and emergency department visits, which is of great interest to all hospitals and health systems. Next slide, please. So in 2014, Marian Regional Medical Center began, and we were clear in targeting our population because it could be different groups. When we talk with others now about replicating and scaling our ideas, I believe the best population is medically fragile older adults, typically defined as 65 and older with a series of other eligibility challenges. But we kept it loose on purpose to get buy-in and get people used to, hey, this service is here. And for us, it was very, very important that we succeeded in embedding this caregiver as an advocate and someone recognized within the health system. For instance, we created lanyards with badges for them so they were identified. We give them portfolios with the caregiver program logo on it so that they're identified when they come to various departments getting imaging or they go see their doctors. And we also give them a personal health record to keep tabs so that they own more of their obligation to help us help them by reporting and tracking. It's been very effective. They appreciate it and they show up with these things. Next slide. We approached the development of our community-based caregiver program by creating a collaborative, creating a mini community benefit organization grouping. And some of these partners, many of you have interacted with in your communities across the country. The Area Agency on Aging and the information and referral services was very important coming into this work. And lots of things, anything from food insecurity to transportation, how to get access. So we bridged the gap with these caregivers we're working with by bringing these to the table. We created a very small, large print, customized subset of what goes into the Area Agency on Aging's major tome of information and referrals for older adults by making a 4-page insert that just had information specific to what a caregiver of a fragile older adult might need. That's been very much appreciated. And other partners then who provide coping and support counseling, adult day health, disease education, telephonic telephonic support, adult day health, and some other tools and services, care mapping, which is an interesting resource our navigators use, which is an exercise to help caregivers identify their world around them of both support and acknowledge that they're caregivers of more than they think, and no wonder they're tired. And it can be quite helpful. And we've done quite a bit of work in these years since, later, it wasn't the beginning step, of building a respite volunteer program. Next slide. So back to embedding. When we started the program, we identified our population, as I shared, but you have a choice. We want to make it a navigation model where someone connects and points the way and holds your hand while you learn how to be a savvy caregiver. Same model we put in our cancer centers, navigators to help vulnerable people find their way when they're stressed. But that navigator could be either a nurse or a social worker, and it may be different as these programs replicate depending upon where they're put in the system. For us, we had a well-established care transitions program of nurses who managed telephonic oversight of patients who were at high risk for readmission to the hospital, mostly chronic disease. So we knew we wanted a social worker, unique skill set specifically prepared to do counseling, to work with the family member, and to be focused on the social determinants of support for that individual and then the diet itself. So we picked a social worker and fit it within that program. That has been a good choice, and we have not found any reason to change that. Next slide. So Feline introduced the Caregiver Navigation Toolkit. So later on in our process, with the support of Feline and our partnership in scaling to a different area with the additional hospitals that she mentioned in the current scope of work, we knew that we needed to move forward. We needed to have a toolkit, something that we could take the experiences that Dignity has had with their 5 years of programming up here and hand it over to somebody and counsel them, of course. But if you follow this, you've got a program that has proven results. Next page. Out of this document, I'd say this is the most important page and the one easiest to speak to share with you a little bit about how this can be used to create another program. So at the top there in the green bubble, this is where we talk to interested hospitals and other groups about building a caregiver support program. And this is where we talk about you're needing a program coordinator. We call it a navigator. And think about what kind of navigator you need. Figure out your patient population and decide probably if it's a social worker or a nurse. It could be others, but that would be the most typical. In the blue bubble going clockwise, we include in the caregiver toolkit samples of initial home assessments and ongoing documentation tools. We include photos of the gift basket. This gift basket, and I did not include a picture of it for today, but this gift basket that the navigator puts together has been an interesting learning, certainly on my part, because it's a simple little dollar store, self-care oriented, customized to the caregiver being approached. But it's a little thing, but what it says is, I know you're busy. It's hard for you to accept help, but I have some ideas. I think I can help, and I recognize you as a caregiver who's struggling. Let me come, and I have a little gift for you. And it opens the door all the time. It's very important. We also, as I think I mentioned, we have built these folios, and then we've built their personal medical records to go with them. In the gold, following down, finding your community partners, because you can't do it alone. In all of the not-for-profits that do great work in your community, bring them together, whether it's in a formal collaborative, such as what we did, or not. You need to identify the partners that are going to be there for your caregivers, that your caregivers, when you make a referral for Meals on Wheels, aren't going to sit in a line that could take 3 months, because that is a treasured, rare resource. You're going to have some dedicated partners so that your caregiver, care recipient dyads get what you prefer. Moving down, all of these caregiver, care recipient dyads get a care plan. We, in our program, get a lot of information on the care recipient as well, although our interventions are organized, of course, around the caregiver. We run a standalone electronic medical record for this. It is not embedded yet within what the system uses. That's clearly an opportunity, and we tell interested groups who want to do this to think seriously about that. And better to start with it embedded, but in our system it was not possible. And then referrals, we found it very helpful to not only, of course, make the referrals to what our caregivers would need, but to track it. Because we wanted to be able to say over time which of these interventions was making the most difference. What could we ultimately, if we could do real research, not just track and trend our own experience, what would be the top 2 or 3 things that made the difference? We know, anecdotally, it is the navigator itself and then a few other things. To the pink, education. Lots of educational resources are put in the toolkit. There's lots out on the internet. Websites are in the toolkit about where to get things that we have found to be valid, evidence-based tools, ideas about how we can do this much the same so we can compare results. But the Powerful Tools for Caregivers class seems to be the best tool that is evidence-based, originally conceived by Stanford, privatized, and so we have adopted it. It is a 6-week course. I am continually amazed. I would have thought when we began this that we would not have busy, burdened caregivers willing to step out and attend a class, but they have extraordinary run these classes. They're 6 weeks, 6 Saturdays typically in a row, and without fail, 10 or 12 people are in that class. They do it, they love it, and say that it makes a huge difference. That was a learning, a surprise plus learning. And then the integration. This is an ongoing opportunity for us. How to integrate it. So I told you how we started, but there's been lots of other ways to embed this program and integrate. We're a site where there's a large family medicine residency program. So now we've embedded it by having the residents learn about it and go with our go to our caregiver's home as part of their community experience. And then we made that even better by having them go to a palliative care, which is palliative care is those patients that are on our services have lots of complex problems. Maybe the patient, you wouldn't be surprised, might die within the year, but it's not ready for hospice. So we do have a lot of those types of patients, and mostly it is grappling with the end stage of chronic disease. So we have the residents go with our navigator to the family caregiver of those patients. So that's been extraordinary for their education. So lots of little ways that it keeps expanding that speak to how this is being integrated and embedded. And monitoring and evaluation. This is huge. This is where we're at in our programming. We're collecting data. We have reams of it. We're looking at different metrics. We began to look at depression as an example. You heard Feline speak to caregivers being at more risk of suicidal ideation or worse. For some reason, in our population, we did not find depression as a major feature upon enrollment to the program. And then we periodically test that with one of the evidence-based questionnaires. And so there's more, but I did want to share with you some of our results to date that are pretty compelling, I think. So next page. We try and use evidence-based tools wherever possible. We use the Zaret burden scale. We use the short scale, the 12-point scale. And this is administered upon enrollment into the program, and then ideally at about 60 days later. And over time, this has been 3 years now collecting data, over time, 80+% of the caregivers do report an improvement in their perception of burden, that it feels better, it's lifted, it's more manageable. Some report tremendous, dramatic improvement, and some, of course, none. You expect that. But to have 80+% continue over 3 years, we're doing something right in helping manage or lighten the burden. Next. This one is quite compelling. As I mentioned before, we track emergency visits, and we track hospitalizations. I track readmissions as well because, again, hospitals and part of a health system care very much about not having patients they've cared for go back into the hospital. It's not good care, and it is also something that Medicare now penalizes for as well. But in this program, I'm particularly interested in hospitalizations at all for these medically vulnerable older adults we're caring for and their caregivers. Any entry into the hospital emergency room is, I think, can be equated to pain and suffering. It's challenging. It's not a good thing. It has to happen sometimes, but this program consistently has been very successful in contributing to the reduction, you see on the far right, of, it runs 38 to 48%, but 43 so far in the 3 years, plus reduction. And what we do is we look at 6 months prior into all the hospitalizations a patient of that caregiver has experienced, and then they're enrolled in the program, and then we track them for 6 months afterwards and report off on any hospitalizations. It's dramatically different. The same thing with the emergency department admissions or visits, less of a dramatic change. Probably lots of reasons for that. Access to primary care, things that maybe haven't been fixed yet, but still a reduction. But the hospitalization number is huge. And we do show this quite frequently, and it piques interest and has been quite helpful in articulating the return on investment outside of the sheer return in that it is good patient care. The next slide. As part of the community caregiving initiative, evaluation specialist was used to do some of the metrics on a big picture for the foundation. And their interim report, I threw this up because I think it spoke specifically to what we were trying to accomplish as well. And that their findings at their mid-year report was that these family dyads, these caregivers, reported out that they were much more able to get services for their loved ones. And they were more confident, and it was evident that our navigators were better at making sure they got the services they needed. And back to sort of the embedded part of what we want these caregivers to be as active advocates for their loved ones, that they feel better, more empowered to work with medical providers, and they're actively involved in care decisions. That was very good things to hear. And next slide. Some lessons learned along the way. There's many, many, many. But as I already mentioned before, that busy schedules of these caregivers sometimes make getting help difficult. Give them that basket. That the support is effective through visits and telephone and technology. So one of our next phases is use of different technology in this work. The culturally specific outreach to the population of caregivers is very important. I mentioned, but didn't highlight too much, we use extensively the Promotora Network in Santa Barbara County. And the Promotora model, if you're not familiar with it, is essentially a program of using individuals, lay individuals interested in giving to their community in the Hispanic communities, and they're trained, gives them health education training, and then we send them back out and they work with our navigators, and they're very, very effective in getting us in and helping with that population of our caregivers. Local implementation is critical. These community stories and how it works on the ground is important. And I do believe that we've seen that partnering in some way with a health system has numerous opportunities for continued sustainability of these programs. And the need is there, of course. And next slide. Just some collateral material that we've built. There's lots more. And that I'd share. And last slide, please. So I thank you very much for the opportunity to speak with everybody out there and share this. It is a labor of love and a tremendous program that we intend to scale across the system, and right now in partnership with Feline in her new project.
Well, thank you both so much for this really wonderful presentation. These are complex and difficult issues, and it's great to see a specific program on the ground that we can learn from. We do have a number of questions to ask you. We do, anybody else who wants to submit a question may do so. You just type it into the box that you see in the right-hand part of the screen. You just drop down the question box and type it in there. But the first question is for Feline. So not exact numbers, obviously, but could you give us a sense of the scale of the philanthropic investment that you made? And I think the underlying behind this is this something that most local and regional foundations might be able to look at?
Yeah, that's a great question, and I did not put that up there. But essentially, I need to do my math here very quickly. But I think from a perspective of how much we're talking about, one of the things that was really important to me in doing this is because I believe this program is going to show results, was to ensure that that the hospitals also had some, quote unquote skin in the game, if you will. So essentially what we've done is a little bit over, it's $226,250 a year for 3 years. So we're funding half the cost of the project. There's a budget that's included in the toolkit that can help project some of the costs that might be involved with that. Now that is just to implement the project at an individual hospital. That doesn't include, like a large-scale evaluation of all the projects, but that got it launched. So I think it's depending on your resources, and we were fortunate that we had a donor fund that was earmarked for healthcare, and so we were able to tap some of those resources. So, but anyway, I hope that helps.
Thanks. I think the next question probably is for Kathleen. And the question is about, is there opportunities to include information about economic resources, such as access to public benefits or other programs serving low-income seniors into this model? And if you're doing that, could you talk a little bit more about that?
I'm not sure that I understand the question. Sorry.
Okay. So it's about things like, do you use any kind of, for example, a screening tool to find out if somebody is eligible for other benefits that they may not know about as a low-income senior? Is that a part of the program at this point?
I see. I'm sorry. Yes. The navigator is one of the reasons also that it was a social worker who would look at eligibility for other programs, especially when low income. We don't look at them for entry into this program based on income at all, but that is part of what the social worker assessment is.
Okay, great. And I think this one is probably to you as well. It's a question you partly addressed with the slides that showed the decrease in emergency room and other issues, but it says we often have trouble communicating the value of these programs to our hospital leadership because they want to see how we can ultimately save money. Is there a business case for the Caregiver Navigation program? And if so, can that be shared?
Yes, it can be shared. The actual business case to get this off the ground was probably built 6 years ago. So I'd welcome whoever had asked the question to take down my contact information, and feel free to contact me directly, because I would like to share that with maybe truing it up probably.
Okay. Another question, I think, really for either of you. How does this program integrate into the hospital transition program? I assume the one that you had in place before. Is this an addition to that? Is it integrated with it? How does that work?
This is Kathy. From my perspective, it was integrated directly into that program, and that program now has multiple other, it has 5 care transitions nurses that look at risk of readmission of patients. Then the Caregiver Navigator program is sitting with them in the same place. There are 3 social workers now in that program. It's added clerical, so it's grown. And they will then be called in directly from those nurses and vice versa, and share their side of those dyads when need be. And they each get referrals from very similar places. And we have taken it and expanded it to the cancer. We have a large, comprehensive cancer center, a single story, 3-story single place that has a lot of caregivers in shorter run needs, and they are a population they serve now as well. That partially answered the question, I think.
Thank you. So the next question, and I think probably, Feline, you can weigh in on this one, is how do you develop the relationships and build community involvement with a program like this? There was some discussion about some of the specific aspects that, how the coalition was pulled together. Are there other things that the foundation can help with in terms of building community relationships, and how would that work?
That's a great question. I think one of the things that's important, and I'm going to go personal and then I'll answer the larger question, but, as I mentioned at the very beginning of my presentation, family caregiving is very personal, and yet it's so common. And so when you speak to somebody who has where their family has had the experience, it resonates. So it's a place of sort of a human-to-human connection that you can start building on. I think for the foundations, from the foundation's perspective, there were a lot of things going on in the community that were looking at older adults. There's a movement for dementia-friendly Ventura County, and then there was this collaborative that I mentioned to you, and then into this picture is kind of like this whole other piece that's kind of part of the conversation, but not exactly. And one of the key partners that has been just tremendous for our work here has been the Hospital Association. And that just happened by me meeting somebody who was at the collaborative. And, I'd been trying to determine, well, what's the best approach here? When I was in Santa Barbara County, of course, Kathleen and I worked together, but here I'm newer to a new community, and where do I start doing the outreach? So the Hospital Association representative, Audra, who's mentioned in the toolkit, and I had coffee, and I sat down and I just said, Audra, I have this program. It has benefited hospitals. And because she also had a personal experience with caregiving, she just said, oh my gosh, this is fabulous. And she immediately saw the value in it for patients. And because of that connection, she was able to open the doors to the leadership of the hospitals for me to make a presentation to their CEOs and for us to continue to have a relationship with them, to be educating and creating that kind of awareness and openness to this kind of an intervention. So that, to me, it's all about the relationships, who the people are. I'm not suggesting that you go out and go, are you a family caregiver? But, when you speak to somebody about it and it's something of which they know, it will speak to them inside, and they generally will understand what you're talking about. So that is, both of those things are really helpful in building relationships.
Because we've had, go ahead.
No, go ahead.
Because we had several questions that come in about this. We will be sending out a follow-up to this to everybody that's on the call today, and we will include the links to all the resources and tools that have been talked about. So the toolkit and other things, a video about how the program, following the program in an actual hospital setting, and a variety of other wonderful tools that our speakers have developed will be made accessible to you. So we're pretty much out of time for the questions, but I do want to come back to both of our speakers today and ask you for your final words of wisdom about this important issue. And Kathleen, let's start with you.
I think if you are a provider system listening and hesitating about investing in caregiver support, stop hesitating. The ROI will work itself out, and it will take off and improve the overall care and your patient experience results incredibly. If your caregivers out there, look for these programs. They're probably in some fashion in your communities. And if you're a funder, continue to, this is a long-term effort, and we're only part of the way there. Look at this space very closely. It's a good one for you to invest in.
Great, thanks so much. Philly?
You know, I've been involved with this work for a number of years now, and I think that there's just something very profound about the community coming together to understand that caregiving is really an important issue that we need to pay attention to, and to see it really evolve and morph into what it has here is a very compelling thing. But Kathy mentioned it already, it's a long-term play. And, you know, oftentimes urgent things will take priority, but if we keep our eye on the future, on those trends, those demographics, and knowing that at the end of the day, we're all caregivers, you know, that this is really about all of us together, and it's going to take the lift of the community to do it. And so to have healthcare be one of the key partners in this is so crucial. And I would just encourage anyone that's listening to figure out what role can I play in helping to bring this forth. And I will say the area is still in development. The data needs to be gathered. I think what sells the program right now is the fact that there has been data gathered by Kathy and others. There's more work that needs to be done there. There's more that needs to be learned. And we're all learning together and creating that kind of environment where together we can learn is what is going to help us get the information, get the data, figure this out, and be able to help our communities and our country address the caregiving challenges of the future. So.
Great summary. I want to thank Feline Wiggins and Kathleen Sullivan for their presentations today and for the great work that they're doing to give us examples of how we can do better on this important work and how we can integrate them into the healthcare team. I do want to thank the Johnny Hartford Foundation for their support of this webinar and the whole webinar series that we present once a month. We'll be making the presentation available to anyone who wishes to view it later, including both the slides and the audio. You can watch for an email from us to be sent in the next few days, or you can always look on our website under the webinar page. And finally, I want to thank all of you for participating in today's webinar. Have a great day.